I'm so excited to be here with you today. This is awesome. You look around the room, you can see that there's some people that are interested in this. What you don't see, maybe the folks online don't see or altogether, is that actually we're about 1,800 people participating actively in this discussion right now, which is more than double where we were last year. And there have been online already approaching 1,000 conversations and comments of discussion on what's being talked about in the panels today, and ideas and brainstorming of what we do to reduce burden. And we've covered a tremendous amount of ground, right? So we heard from Alberto Colón-Vieira's panel on transparency, which pushed us to think about differently how people define and interpret transparency, how we can empower patients with clear, usable information without compromising privacy. Dr. Sherry Ling and her team speaking to us about transforming chronic care, which gave us a real look into what's working, the challenges that remain, and how we can better align policy and payment to improve lives. And then, of course, the AI panel just now with Patrick Newbold, in which we moved beyond the hype to show concrete examples and challenges of how AI is already empowering clinicians and patients to do their best work, giving us a clear view on how we can better support care with less burden. So that's the what of what we've talked about today. Let's talk about the so what. Why is this so vitally important? It's not just an academic exercise. It's not just a nice convening of 1,800 people spending a day to talk about burden and then go about the rest of our time doing nothing about this. The burden that we're talking about has a real human cost. And I'm reminded of this weekly. So I'll give you a couple of anecdotes. First, I've got a neighbor. She's lovely. She turned 65 in October. I was out of town, and she's amazing. This woman will take our garbage cans out and back in at like 6 in the morning if we forgot. She's out at 6:30 blowing the leaves from our sidewalk. She grabs packages if we're traveling. I was out of town last week, and she grabbed a package for me, and I went over late in the evening after I landed to pick it up. And she said, "Hey, you have something to do with Medicare, right?" And I said, "Yes, I do. Shart, so good to see you. How are you?" And she said, "Well, I turned 65 in October, and I'm still not on. And I've been trying, and I've been bounced back and forth between a ship and a broker. And the last time you talked to me, you told me to call 1-800-Medicare, and I've gone to Medicare.gov, and I can't get on. And they talked to me about like I could stay with my Blues plan, or I could go to this other one, or there was this A and this B thing. And it's not working. And the latest is they told me I need to go down to the Social Security office, but I don't know why." And she was a little annoyed. And I was trying to help her, and it turns out that I run Medicare, and I was a little stumped. And it got awkward because I should have been able to help. And I said, "Well, I've got amazing people, an amazing team. We're going to get this sorted." That was a failure of the system. That was unnecessary burden. That's unnecessary stress on her. This is a woman who's worked her whole life. She's counting on the system to be there for her. And the first interaction that she's having with it is letting her down. A wise CMS administrator gave me counsel before I took the job last year and said, "You have an incredible team of ombudsmen, and they're going to field beneficiary inquiries when they have challenges. But I'd really encourage you to spend a little time talking to a beneficiary every week if you can." And this was good advice because I oversee a $1.1 trillion program. I have 68 million beneficiaries for which our team is responsible out of the 170 million beneficiaries that CMS is responsible for, on top of the other 170 million Americans who get their insurance elsewhere, but for which we are the rate, benchmark, and policy setting engine of US healthcare. And so I've made it a point to answer phone calls or emails each week from a Medicare beneficiary, not just send it to the ombudsman, despite the fact that my team telling me, "Hey, you're pretty busy, and like we've got an amazing team," and we do, to handle that. The blessings of that are multiple fold. One, I, with my finite capacity, have a hard time wrapping my head around $1.1 trillion and growing fast. When I talk to a beneficiary who just had all their teeth pulled and exhausted their bank account, and they're told that they had coverage for dental, but they can't figure out, and they're desperately trying to get somebody to help them, and they have clawed their way to find an email or a phone number randomly to the person who runs Medicare who happens to pick up. That's a heartbreaking story. Or the person who's trying to get their medical records to go from one provider to another in order to get the care they need. Or the other beneficiary whose care is being denied by their plan, and they don't understand why, but they know that they're getting sicker and no one is helping them. That's the result. That's the human toll of burden. I was just with the American Medical Association this morning, speaking at their Leadership and Advocacy Conference alongside the Director of Center for Medicaid, Dan Brillian, who's extraordinary. And they asked a lot of questions about burden. They talked about the 2-to-1 ratio of administrivia over patient care, despite the fact that each of those physicians went to medical school and got into healthcare to deliver healthcare, not to manage burden, not to manage administrivia, not to manage paperwork. And yet the system has imposed this on them, and it's everywhere. At the same time, we shouldn't do out all burden. Some burden is actually appropriate. It promotes program integrity, it promotes safety, it promotes quality, it drives accountability, it makes sure that we're managing appropriately our sacred stewardship. And by the way, it is a stewardship, it's a calling to be in this industry, to serve these people. Some burden's okay, and we don't throw it out because then there will be cost. But our goal should still be to make that burden invisible so that it doesn't impair the fundamental underpinnings of the program that we all serve. And so it's not an isolated story, my neighbor trying to get on Medicare. It's not an isolated story of these beneficiaries or these providers who toil under the burden of an unbelievably, unfathomably phenomenal healthcare system that is simultaneously unbelievably and unfathomably complex and burdensome. And so we have to do work. If the system is hard for us, all of us, as policymakers, as practitioners in the system, as physicians, to navigate with all of our tools and our relationships and our knowledge, imagine what it's like for others in their moment of peak uncertainty. We can do better. And that's what today has been. And I am encouraged. I'm optimistic. But this is a call to action. This is the now what. So what do we do going forward? How do we build a better healthcare system together? We have 3 powerful ways in government to make change. Number 1, and you've heard Dr. Oz talk about this, and I'm going to repeat it. We can legislate. We have 535 people on the Hill. That's what they do full time. And it's powerful and it's lasting, but it's a little unpredictable and we don't quite know the timing all the time. And it can be a little brute force. It's not quite surgical. And then we have regulatory. That's what happens in these walls. But the problem with that is it takes a long time. And again, we're still a little removed sometimes from being right on the ground with the problem. And when somebody doesn't like the regulation we pass, they may have a lot of resources and they work to engineer around it. And then we also have the power to convene, which is what we've done today. And you've all answered that call. You showed up, 1,800 of you, who all are busy, who all have valuable time, who have things to do. You showed up to answer the call, and we're grateful for that. And so let's understand what that means. And then how do we, CMS, empower you? How do we level the playing field? How do we empower insurgents to take on incumbents, to take on the incumbency of burden? And then how do we reinforce that? How do we memorialize that through the power of regulation? We have big wins to build on for what it's worth. We're not starting from ground zero. Many of you have been involved in these big wins, and we're seeing progress. From the very beginning, one of my priorities alongside the secretary and the administrator was prior authorization. We started on it on day 2. We've made extraordinary progress there, both with our regulatory tools and the power to convene, with industry coming together to address what we know has become a corrupted system. It was not always that case. Prior authorization was a tool that was developed shortly after World War II. It had 2 key objectives. Number 1, very surgically, to try to control cost, to manage affordability in select instances where it might be getting away from us. And number 2, and the more important thing that we all forgot somehow along the way, was it was meant to provide a team to an individual physician or provider to double check, to make sure that the clinical pathway was the best, safest thing for the patient. That was a good thing. We're better together. Sometimes multiple minds thinking about a complex problem can produce a better result. And then somewhere along the way, in the 70s through the 90s, utilization management as a construct developed, and then we started to see a little bit of weaponization of prior authorization. And I would argue that was the wedge that was driven most profoundly between providers and payers. It wasn't the rate negotiations, it wasn't everything else, it was that. And it fractured trust, and it imposed a burden everywhere on the system, and the patient was caught in between. And we all know it. And there's truth on both sides. Providers sitting and saying, but they want it. They want to deny care. They make more money. They want to take the float. Maybe that's true. Payers sitting saying, yes, but if left unchecked, costs will balloon and we're the ones getting beaten up. And we have to control costs. That's our job. Perhaps that's true. But there's truth to both. And there's an opportunity to do better. It's 2026. We have unfathomably incredible technology. We just heard about some of it on the panel. We don't have to impose a time burden on providers and on payers that's unnecessary expense to figure out what the best clinical pathway is for the patient, if it's appropriate, for the thing that they depend on in their moment of greatest uncertainty when they need answers. And their trusted physician is trying to help them get those answers. And so we convened with the payers. And payers representing more than 85% of covered lives in the country made commitments to reduce the volume of codes requiring prior authorization, to shorten the time frame, and increase the transparency, to eliminate or make invisible the opacity of that process for providers and patients alike. And then importantly, by 1/1/27, to make sure that electronically, in the native workflow of the provider, at least 80% of the remaining codes that required prior authorization would be adjudicated in real time in the physician's office while the patient was still there. And then our good folks at CMS came right along and are pushing regulation to reinforce that, to help good people make good decisions. Because I believe good people do go into healthcare, with rare exception, but sometimes the pressure to perform obscures priorities. And ours is the opportunity, it's the privilege to get to remind people why they're here. What is that calling to serve? What does that mean? How do we do our best work? We're doing other things as well. Some of you have heard about Claims Core. Right now we process $1.5 billion of claims a day in original Medicare on a platform that was written in COBOL in the 1970s. Imagine that for a second. Hundreds of billions of dollars going out in code that we can't even find programmers to write. We have to spend extra money to train them to come in to learn something that was a language written 60 years ago. And so we're ripping it out from the studs and we're putting a new modern system in. What does that do? It gives us certainty, it gives us speed, it gives us integrity. That's something that reduces burden for providers, so that they don't have to worry about what they're getting paid. More importantly, because CMS, it turns out, is already one of the best and fastest payers, it sets the pace for everybody else in the industry, that this is what we expect, that games are not to be played in things like payment. If you want to compete, you show up and compete by helping people live their best, healthiest lives. That is how you add value. If you don't want to play that game, get out of the game, get off the field. And so that's why we do this work. Claims Core isn't about saving money. It will do that. It is about improving quality, is improving the patient experience, the provider experience, because it reduces burden. It makes that process invisible. And so we're embracing technology, we're embracing AI, we're doing many other things. We have smarter payment reform with models like Access and others coming from CMMI. We're unlocking data liquidity through the health tech ecosystem. Many of the work that our colleagues at ONC and ASTP are doing, Andy Gleason, Tom Keene, others. We're pushing bold deregulatory actions that could be relaxed because, while well-intended, perhaps did not promote patient safety and quality as we might have expected, or maybe are perhaps less necessary now. So again, let me be clear, not all burden is bad. But if it's burdensome, let's work to make it invisible even so. So the momentum today, what are our next steps? The momentum today cannot stop. I am pleading with you not to walk out of this room or to click off online and think, okay, that was fine, and then not think about it again. We have to let this be the beginning of the next chapter. We have to be committed, and we are at CMS committed to working with all of you, our partners, to build a better and more efficient healthcare delivery system. And so I have two key asks. We need your ideas. Number one, what administrative tasks are genuinely necessary and improve care? What do we need to not get rid of? And number two, what policies, however well-intentioned, could be reduced without harming patient care? Please send us your feedback. You've heard the email address before. Unfortunately, it is a little burdensome, but we won't worry about that. Burden Reduction Conference at cms.hhs.gov. Again, Burden Reduction Conference at cms.hhs.gov. I can commit to you on behalf of our team that we really do and will read every single email that gets sent there with ideas. They may not all be actioned upon, but they will be well considered. I also encourage you to work more closely with our teams on the things we're already doing, on Claims Core, on our models, on prior authorization, in the health tech ecosystem, et cetera. There are many places to begin. But most importantly, and best of all, on behalf of everyone at CMS, thank you. Thank you for your energy. Thank you for your ideas. Thank you for your unwavering commitment to the American people and making this the best, least burdensome, system on the planet. We are so very grateful. Thanks for being here.